Good day to everybody. It's a pleasure to be with you, even at a distance, and it's an honor having been invited in this fantastic seminary on pregnancy and kidney disease. I am Giorgina Piccoli. I am an Italian nephrologist, but I live in France since 8 years, and I started my interest in high-risk pregnancies started with two high-risk pregnancies 27 and 25 years ago that ended up in one son and one daughter in good health. This is my team, Massimo Torregiani working with me here in France, Rossellattini is an obstetrician working in Italy, and Gianfranca Capiddu is my half-sister that works in Sardinia, Italy. None of us has any conflict of interest. So I have been challenged by this case of a 25-year-old young lady presenting with edema and was found to have hypertension, nephrotic range proteinuria, serum creatinine already slightly high, and underwent a kidney biopsy that found IgA nephropathy. She was started on antiproteinuric measures, but she defaulted treatment and was lost to follow-up. But 3 years later, she presented again with hypertension, always proteinuria, and a serum creatinine that was even higher than 3 years previously, and she was pregnant 14 weeks and wanted to continue the pregnancy. So, young woman, hypertension, lost to follow-up, no counseling, moderate progression, and at 14 weeks she has proteinuria, hypertension, and presumably CKD stage 3, 3B. It all depends upon her body size. So what to do? Well, this is what I would like to share with you, the theory and the practice, starting from counseling and then going through the round trip from CKD to pregnancy complication and from pregnancy complication to CKD. And noticing also something that we have to think about after this complicated journey, that's about the children. There are also a few pragmatic management points that are actually the core of this discussion. So what's the context? Obstetric nephrology is a very new subspecialty, and it started not so well because up to even on great journal like Lancet and great experts tended to say, do not have children if you have kidney disease. Beware of that. However, reproductive health, very broadly defined, but including the capability to reproduce and the freedom to decide if, when, and how often to do so, is a well-acknowledged right. So, when we consider the fact that things changed only recently, it's not surprising to understand that our knowledge on women's health as adult nephrologists is relatively low, as this nice study shows. But it's not just because we are used to see older people, because the same problems are shared by pediatric nephrologists. So we have to be honest and to think that we have to learn more, and a meeting like this one is very welcome in this regard. So counseling may be done in different ways, whether before pregnancy, as everybody says should be done, but at least in our experience, less than half of women actually undergo a pre-gestational counseling. And there are very many barriers to pregnancy in CKD. Psychological, fear of risks, sexual dysfunction, but we know that our patient got pregnant, so this is not a problem. Low availability of preconception counseling, which is a very, very important problem. We can face counseling in two different ways. We can face a warning-based counseling that underlines the importance of the problems these women can have and starts from the worst case scenario. Such a counseling is very informative on risks, may protect physicians from rather important criticism and legal actions, but may make leaving pregnancy a hell, may scare the people and put them in a very bad mood during pregnancy. On the other hand, what we try to do more often is a success-based counseling that may help to understand that there is always a best case scenario, but is not for everybody, is not frequent in advanced CKD, but is something that can give hope, and giving hope may put people in a better mood towards compliance. On the other hand, it may lead to underestimate risks. The best case scenario is the perfect one. Everything's fine, baby born at term or near term, no need for hospitalization, ICU, and CKD is stable. This is almost the rule in CKD1 without hypertension and proteinuria. But as soon as we go higher with CKD stages, hypertension and proteinuria, we have more often intermediate scenarios in which the baby is born preterm but does not go so badly and needs some special care, and maybe the kidney function worsens, not in a dramatic way. But there is always, and we have to be aware about it, a worst case scenario in which the baby dies in utero and or the mother needs dialysis and or a very preterm baby is born and does not make it through life. So the reason why we prefer to work with scenarios is the fact that we have no magic number on any of this item. Probability of a live-born baby, it depends also very much upon the availability of care. A full-term baby depends more upon the maternal situation. Development abnormalities that are not just congenital, they may also be linked to very early preterm delivery and possibility of preserving the kidney function. We know these are risks. We know they increase with CKD stages, but we have no number to quantify them. There was an attempt to define mildly increased risk, moderately and highly increased risk. Blood pressure in highly increased risk is poorly controlled. Proteinuria is over 1 gram. eGFR is less than 60. Actually, this is the case of our patient, but things are not so simple. It's very different if she was not treated for hypertension and comes hypertensive, or if she has a resistant hypertension, for example. So the conclusion of this paper was that everybody can make it, but there is a high heterogeneity of kidney disease, and we have to admit that our knowledge is limited. Counseling is advising on risks and chances, and there are some things that we cannot modify, like age, ethnicity, social status, and then the presence of some particular diseases. So before giving an idea to this young woman of which are her risks, we should know something more about what did she drop from follow-up, why did she come back? What does she do in life? What is her social status? Is she taking any medication? Do we have some data in the last to follow-up period? How is her serum albumin, total proteins, coagulation, and not only? So let's look a bit to the reference clinical data, back and forward, CKD and pregnancy complications. We know that about 3% of women in childbearing age has some form of CKD, even if those who have severe CKD are much less common, but are not so exceptional. And very often pregnancy is the moment in which we discover this. Which are the main risks for the mother? Maternal death, rare, very rare in high-income countries, but not so rare in low medium income countries. CKD progression, this is a problem if CKD, in advanced CKD. Immunological flares and transplant rejections are always possible, but probably less frequent than in the past. But abortion, stillbirth, and prenatal death are relatively common with advanced CKD stage, especially in dialysis patients. What about the baby? They are often small or very small, but more than the actual size, what's important is their centile. Were they grow restricted, exposed to hypoxia during pregnancy or not? The good news is that we do not have an increased number of malformations except those linked to hereditary kidney disease. And we will speak later about the baby's health. So, small babies are not alike. Babies who grow over their normal line have probably a better outcome independently from their weight from babies that started well and then had a flattening of a growth curve. Risk of all adverse pregnancy outcome is increased. There are a few systematic reviews, but in the end, they just say it's risky. But it's very difficult to say how risky in which stage. This is why I'm showing you some data from our group. At that point, there were about 500 patients in this large cohort. Now we have more than 1,000. And as you can see, all the risk for the baby, preterm, early preterm, cesarean section, and small for gestational age baby increase going up with CKD stages. And the same is for the mother. The latest stages have a higher risk of further impairing kidney function. But let's look at one outcome, early preterm delivery before 34 gestational weeks. In our population, the risk in the low-risk pregnancies is about 1%. It rises to 3% in all patients, stage 1, without hypertension, without proteinuria. Nothing is trivial in pregnancy. But this is more interesting. If stage 1 has either hypertension or proteinuria, the risk is about 20 times higher. And if we deal with stages 2, 3, 4, 5 without hypertension and proteinuria, the risk is the same. While if we combine higher stages, hypertension, proteinuria, roughly half of women have an early preterm delivery, and we are here with our patient. But let me just underline that the risk is not just linked to CKD stage, hypertension, and proteinuria, because even kidney donors have a high risk, and even patients with urolithiasis. Nothing is trivial in kidney in pregnancy. And this is the last paper we recently published on the TOCOS cohort on Kidney International that shows that even having an interstitial disease or having a history of acute pyelonephritis is associated with a shorter gestational time. It's not a disaster, but we have to take care of them too. And of course, if we have patients with more advanced CKD stages or hypertension and proteinuria, the duration of their pregnancy is low. What does it mean in terms of risk of preterm delivery and preeclampsia? Well, we consider that there is a balance between placentation, highly impaired placentation, early preeclampsia, but even when the placenta starts well, having kidney disease may change the balance and increase the risk of preterm delivery, early term delivery, and preeclampsia. But what if they combine? This is a nice study on IgA nephropathy fitting to this patient. It tells us that if we are lucky and the patient has a non-complicated pregnancy, her risk of progression is low, but if her pregnancy will be complicated, we have to take even more attention, pay even more attention to the evolution of kidney disease. So in this case, to be able to answer to some of the question, we should know, is she taking any medication? Hypertension without treatment is different from hypertension on treatment. Do we have some data on the lost to follow-up period? If she had a higher serum creatinine, let's say 2.1, and now is 1.8, this is a very good prognostic sign, but the opposite is a bad prognostic sign. How is her serum albumin, total proteins, coagulation? Albumin may be even more important than proteinuria. So, to summarize this first part, CKD is always a risk factor for adverse pregnancy outcomes from each stage. The reduction in kidney tissue is associated with higher risk, so don't forget making ultrasounds, and all risk progressively increase in CKD stages in the presence of proteinuria and hypertension, but let's not give number. We have no number. We have to admit that we cannot quantify and that we hope to go towards a good pregnancy outcome.